Hello once again, students. And now we are going to cover the second part of Chapter 2 and look at prenatal development. You can see the topics listed here, as well as the section on birth. So let's begin with the three periods of prenatal development. The first of the three periods is the germinal period. This occurs in the first 2 weeks after conception, where fertilization takes place. It includes the creation of the zygote, that first one cell of life when a sperm meets an egg. The continued cell division will happen during these first 2 weeks, where that one zygote splits and becomes two cells, and the two cells will then split and become four cells. Once again, that is the process of meiosis, mitosis. It's a process of mitosis where the cells split and duplicate themselves. And at the end of this 2 week period, the zygote will have attached to the uterine wall and anchored itself there. At one point along this journey, the zygote is actually going to become what we call a blastocyst. This is where, rather than just a clump of cells in a ball, they actually start to differentiate now. And with the blastocyst, there is going to be an outer ring of cells called the trophoblast that's going to eventually be the support system for the embryo, and there's going to be an inner cell mass, which is going to turn into the organism itself. So the blastocyst, it will be surrounded by the trophoblast, the outer layer of cells. This is a picture showing the journey during the first 2 weeks during this germinal period. So you can see the ovary there, and at some point, ovulation during the monthly cycle, the ovulation will take place, and a single egg cell will be released from the ovary. It gets drawn into the fallopian tube. If there is sperm in the system, then they will be swimming up these fallopian tubes, and if it's at the right time of the month, they may encounter this egg that has been ovulated, and fertilization or conception may occur. What else here? So it is approximately a day and a half or so after fertilization or conception takes place, the first cell division will complete. So this is at the 36-hour mark after conception. Then following that, there's about 2 to 3 cell splits per day during the next few days, as 2 become 4 and 4 become 8. Once again, this is the process of mitosis going on. And finally, you can see over at number 9, you can see where the mass has now become blastocyst surrounded by the trophoblast, an inner cell mass with an outer ring of cells around it. You can see that by the end of this 2 week period, at the 11 to 15 day mark, number 11 there, you can see that the blastocyst has become implanted into the uterine wall. Okay, and this is the first period. It involves conception, the cell splitting many times, eventually becoming a blastocyst, and implanting in the uterine wall. The second stage of prenatal development is the embryonic period. So during this stage, we refer to the organism as an embryo. It is as you can see, it's a 6-week period, and finishes around the 2-month mark of pregnancy. The rate of cell differentiation intensifies, meaning that cells start to take on different purposes. So originally, just to go back for 1 second, during all these initial cell splits, the cells were all identical to one another. They didn't have separate purposes. Once the blastocyst formed, then there was a little bit of differentiation. There was an outer wall plus an inner cell mass. Now we get a number of different types of cells forming as differentiation intensifies. There are actually 3 layers of cells that form: the endoderm, mesoderm, and ectoderm. The ectoderm is the outer layer of cells. Sorry, yes, the ectoderm. Sorry, and one way to remember this is that they both have a T in it. They sound similar, ecto or elter. So it's how I remember it, ecto, elter. Anyways, this is what's going to become the nervous system of the organism, and also the sensory receptors and skin parts. So it's the outer layer. It ends up becoming your skin, your senses, and once again your nervous system. The middle layer is the mesoderm. They both start with M, middle, meso. This becomes your circulatory system, your bones, your muscles, and your excretory and reproductive systems. And finally, you have the endo, which is the inner layer, endoderm, inner layer. So they both have an N. I always remember that, endo, inner. And this becomes your digestive and respiratory systems. So the cells are taking on different functions in these 3 layers. The life support systems for the embryo form during the embryonic period, and organs appear through a process called organogenesis. Organogenesis. I have that on a slide coming up, anyways. The amnion surrounds the developing embryo. It contains a clear fluid, which of course we call amniotic fluid. The embryo floats within the amnion. The reason that the embryo is surrounded by this amniotic fluid is to provide temperature and humidity control, and also it acts as a shock absorber. So if the mother's bouncing around somewhat, the baby's not bouncing around quite as much because it's immersed in this liquid. And the liquid, once again, also helps to keep the temperature and the humidity adequate for the developing embryo. Okay. Here we see a diagram of the baby attached by an umbilical cord to the placenta. Within the placenta, there are veins and arteries that come in close contact from the mother system and from the baby system. They intertwine and come in close contact, but they do not actually exchange blood in any case. So there's no direct transfusion between the systems. But what happens is, because they intertwine and come so close to one another, they are able to pass oxygen, water, and salt and nutrients to the embryo from the mother system, and from the baby, from the developing embryo to the mother, it can pass carbon dioxide and digestive waste to the mother system to be disposed of. So she passes oxygen, water, salt, and nutrients. The developing embryo passes carbon dioxide and digestive waste. So there's an exchange of these elements without any blood being exchanged. So this is what the placenta functions for, to exchange these necessary elements. The umbilical cord contains 2 arteries, 1 vein, and connects the baby to the placenta. The placenta, once again, is a disc-shaped, we just saw a picture, disc-shaped group of tissues, small blood vessels from the mother and the fetus intertwine but do not join. I mentioned organogenesis earlier. This is organ formation that's taken place during the first 2 months of prenatal development. So it's taken place during the embryonic period. So the real importance of the embryonic period is that all of the organs begin forming, and in fact, all of the bodily systems begin forming during the embryonic period. There are rudimentary eyes and ears forming, and limbs, and hands and feet. I mean, they're certainly not well formed during the embryonic period, but every system kind of begins to form. The brain has already certainly started to form, and once again, all of the organs. So it's kind of the start of every system, bodily system, and you know, some of them are even well completed by the end of this 2 month period. So this is a really important time. Um, while they're forming, the organs are especially vulnerable to environmental factors and influences. So this is considered the most at-risk time, this 2 to 8 week period in the embryonic period. This is when most damage gets done to the developing organism. It is a time where they're most at risk from things like the mother taking drugs or drinking alcohol or um, whatever, taking pills, or so any kind of environmental influences can do the most harm at this point. Okay, we'll talk a little bit more about that when we get to Trotogens later on and talk about environmental influences. The third period, so we had germinal period and we had the embryonic period. The third is the fetal period. It's a 7-month period. It's the rest of the time, from 2 months until birth. And this is often called the finishing and fattening stage, because all of those organs and bodily systems that were started in the embryonic period all finish developing. And the fattening, so that's the finishing part. The fattening part is that the baby needs to, especially the last few months, it needs to put weight on. It needs to get big enough to be able to survive outside the womb. So growth and development continues throughout this 7-month period. Just a few highlights I'm going to mention. It is around 12 weeks, so around the 3-month period, 12 weeks, when you can determine the sex of the baby. It's around 17 weeks that the mother can feel the fetus move. That's around 4-month period, 17 weeks, that she can first, feel the fetus kicking. And it is around 6 months, or 24 to 25 weeks, that the fetus becomes viable, meaning that it has a chance, at least, to survive outside the womb. Once again, that's around the 6-month, as early as 6 months, or 24 to 25 weeks, it has a chance of surviving outside the womb. If it's on the early side of that, if it was to come out at 24 weeks, for instance, or 23 weeks, 24 weeks, you could be also sure that there would be some lasting damage or disabilities with the baby. If it has even just a few more weeks and comes out around 27 or 28 weeks, it's much more likely to be a healthy, or has a much higher chance to be a healthy infant. Okay, so they say every week matters. Every extra week matters. Okay, let's go on. Although this is interesting, I'm going to let you people read about the brain on your own. And it really is interesting how quickly it develops and how many billions of neurons develop that make up the brain. So do read about that on your own. There's a couple of other slides I'm going to skip as well. You can read about the trimesters. I mean, it's just another way to look at the prenatal development. We looked at the 3 stages prenatal development, which really are from the developmental viewpoint of, there's stages because different things are happening in each stage. This is more kind of from the mother's perspective, first versus second versus third trimester. It's what's happening to the baby, but it's also what the mother's experiencing, and we tend to think of in terms of trimesters when we think about having a baby, but scientifically we tend to look at the 3 stages that we just went over. Okay. I'm just going to slightly touch this section. We'll look at some prenatal diagnostic tests, but I'm going to leave the other 2 points for you: infertility and reproductive technology, as well as adoption. You can read about those things on your own. So let's talk a little bit about prenatal diagnostic testing. Just know that I want you to know the difference between a few different types of tests. The first is the ultrasound sonography, and you can see a nice picture here. And ultrasound uses sound waves, and it is the most common method of checking on the developing fetus or embryo. Actually, I should correct myself here. Now that I'm looking at that picture, it's too clear to be an ultrasound. That would be a fetal MRI. That's being shown in this picture here. That's not in the list that we're looking at, but it is mentioned in your book, and you can read about it. It's newer technology to look at the baby. It's only used in cases where they feel like there may be some kind of malformation, and so you can get a clearer picture. This is certainly a clearer picture than you get with an ultrasound. Okay, so ultrasounds are the most common prenatal diagnostic test. Most expectant mothers have at least one of them during pregnancy, and often 2 or 3 may occur. Chorionic villus sampling is when a tiny tissue a little bit of a tissue sample is taken from the placenta. And this would occur approximately between 10 to 12 weeks. It can occur. So it can be done, by the end of the 3rd month. So fairly early, and you get the results in about 10 days. The amniocentesis is when fluid is taken from the amnion. So amniotic fluid is drawn out. They use a large needle, go through the belly into the uterus and into the amnion to withdraw the fluid. This is typically done between about 15 to 18 weeks. So this is more like 4 months or 4 to 4.5 months into the pregnancy. So a little bit later than the chorionic villus sampling, and it takes 2 weeks to get the results back. So why one versus the other test? So the chorionic villus sampling has the advantage of being an earlier test, but it is somewhat riskier. So if it's not, it depends on how critical the knowledge is to learn about the developing fetus. If the amniocentesis is safer, if they can wait, they would rather do that test. Maternal blood screening is just withdrawing blood from the mother, and there's certain things you can tell by her blood. You can't tell specifically whether the developing fetus has some kind of disease or disability, but you can see if there is an elevated risk of birth defects. So it is maternal blood screening is used. Well, it's a screening tool. It just says, should we go ahead and do further testing? So if there's indicators in the mother's blood, this is what may cause them to do chorionic villus sampling or amniocentesis or a fetal MRI, like we see in the picture here. So it's an indicator of possible problems. Fetal sex determination happens around 12 weeks. I think I mentioned this earlier. So it's around the 3-month period where you can find out the sex of the baby. Okay. I want you to read this on your own. Infertility and reproductive technology, learn about in vitro fertilization. This is just a graph about that. I also want you to read the section on adoption, please. And that brings us to teratology and hazards to prenatal development. So a teratogen is any agent that can cause a birth defect or negatively alter cognitive and behavioral developmental outcomes. Teratology is the study of the cause of these birth defects. So teratogen damage and severity depends on the following 3 things: the dose, the genetic susceptibility, and the time of exposure. Obviously, dose matters. I mean, whether it's smoking, whether it's drinking, whether it's drugs, whether it's, pollution, or, how much you get of any of these things introduced into the body is going to obviously make a difference. Genetic susceptibility differs from one person to another, and that involves both the genetic susceptibility of the mother as well as the developing fetus. So some mothers or developing fetuses may be more or less susceptible to teratogen damage. And the time of exposure refers to the time during the pregnancy. As I mentioned earlier, developing organisms are most at risk during the embryonic period, so in that 2 to 8 week period following conception. This is what they mean by time of exposure. So a mother, let's say, taking drugs at the 6-week mark is more likely to have damage than a mother taking drugs at the 6-month part of pregnancy. Not that that's safe at 6 months or 7 or 8 months, but later in the pregnancy, it is just the less chance of damage to the developing organism. All right, negative exposures, effects of exposure during the fetal period. These are the effects that happen later. If they happen during the fetal period after the high risk period, you get things like stunted growth, fetal brain development problems, organ functioning problems. We're going to look at specific problems that happen if teratogens are introduced at risky times. We'll go over a number of different teratogens here, beginning with prescription drugs such as antibiotics, antidepressants. We don't need to get into all the specifics here. Hormones, Accutane. Accutane is really bad. It was something we didn't originally know about, and there was a number of malformed babies during a time period in the past while we learned about the harmfulness of Accutane, and they now have very clear warnings on packages about not to be taking Accutane while pregnant, because we now know the horrible side effects to a developing fetus. Okay, oral contraceptives can be problems as well. Anyways, so this is just a list of certain types of prescription drugs. The risk factor varies from one drug to another. Obviously, they have volumes printed and in books on this, like little encyclopedia books. I mean, of all the tests that have been done on various drugs and what we know about them. And so they have rating systems of which ones are most harmful, which ones are, have some kind of medium risk or unknown risk, and which ones are safe. And so you can, if you look up this information, as if you're planning to get pregnant, you can make decisions about whether or not you need to switch drugs. Your doctor can certainly help you with this, of course. So, for instance, some antidepressants are perfectly harmless, whereas other ones can be dangerous. Some non-prescription drugs, they mentioned a couple here, diet pills and aspirin in high doses can be problematic. Other teratogens, psychoactive drugs, these can be particularly harmful, at least some types of these. Psychoactive drugs are any drugs that act on your nervous system. They alter your state of consciousness, modify your perceptions, and change your moods. So these are, in many cases, drugs that people take to experience some kind of effect, as an effect in most cases. They include caffeine, meth, cocaine, marijuana, heroin. I'm going to go over a couple of these at least. Cocaine can, as it says here, can cause neurological, medical, and cognitive deficits. You can expect things such as impaired language development is very common with if the mother's been on cocaine during pregnancy. Also, information processing deficits. That's where the cognitive deficits come in. They have trouble, they'll have some difficulties often processing information. So this may include, getting information properly into their minds, or storing information properly. It can affect memory, or it can just affect the processing of information in things such as decision making or problem solving. So there's different ways these cognitive deficits show up. Marijuana mentions here low birth weight and a greater likelihood of being in the neonatal intensive care unit. Other problems associated with marijuana use. One is that there's a higher chance of the offspring using marijuana themselves at a later date. So when they grow up and become teenagers, they have a higher risk of using marijuana themselves. Lower intelligence has been shown in children if the mother smoked marijuana during pregnancy, and also a higher risk of stillbirth. And finally, with heroin, it can cause withdrawal and behavioral problems. Withdrawal issues are things like the baby showing tremors, irritability, abnormal crying, disturbed sleep. Also, I guess impaired motor control would be another one. One of the most common treatments for heroin addiction is methadone. And the thing is that that's associated with a lot of severe problems as well with infants. Methadone is associated with very severe withdrawal symptoms in newborns. So if the mother switches, trying to get off the heroin, switches to methadone, there are just as severe withdrawal symptoms from methadone as from heroin. They have newer drugs to replace that, and for pregnant mothers, they should not be going to methadone. Your book has the name of the newer drug. I don't have it written down in front of me, so it's not that important. But if you're interested, you could take a look at it in the book. Alcohol is another one I wanted to mention. Certainly, alcohol can cause fetal alcohol spectrum disorders, FASD. This is a spectrum disorder, once again, just like autism spectrum disorder. I don't think I mentioned it before when I talked about that, but when you see the word spectrum, it just means there's a wide range of possible outcomes, just as in autism, where there's a very wide range of of functioning abilities in autistic children. There's a wide range of results from mothers drinking alcohol during pregnancy, from very minor results to very major results. Those in severe categories, mothers that have drank heavily during pregnancy, the infants are characterized by learning and behavior problems, as it says here. It's associated with early death as well in FASD babies. Their life expectancy is only 34 years. So we already saw at the beginning of chapter 1, we saw the average life expectancy in the US was around 79 years now. The average life expectancy for a fetal alcohol spectrum disorder baby is 34 years. And the reasons I mentioned here, they suffer early death from suicide, accidents, alcohol poisoning, or drugs, because all those things are more likely for babies that were born with this condition. Also, what we can expect to see is facial deformities, very, very common in fetal alcohol spectrum babies. There's a number of facial features that may be distorted. And this is one of the things that may lead to things like a higher chance of suicide and whatnot. I mean, they're, in a sense, they're marked as different than, in their faces. Okay, nicotine, as you can see, low birth weight, ADHD, more likely impaired newborn brain development, and the offspring is more likely to smoke themselves when they grow up. Okay, a few other ones. I'm not going to get too far into these. Incompatible blood types. This is something that they routinely check for now. Whenever you go in for prenatal care, it can be, if there's an incompatibility between mother and father blood types, it can be very, very risky to the prenatal development of the fetus or embryo. They do check for that, as I said. Okay, let me see what else here. Environmental hazards. This would be like, well, the radiation mentioned that most common source would be X-rays, toxic waste, chemical pollutants are obviously bad. There's maternal diseases that can affect the developing newborn, or developing fetus, I should say. There's a few of them mentioned here. You can read more about them in the book. Some other parental factors, maternal diet and nutrition. The mother needs an adequate amount of calories, certainly when she's pregnant. Proteins, she needs a certain amount of protein, certain amount of vitamins, minerals. So children, if the mother's not getting adequate calories and proteins and vitamins and minerals, it may cause her to be malnourished. And children born to malnourished mothers are much more likely to be malformed and have birth defects. Couple of the common problems that we watch out for is lack of folic acid. It is one of the things that the prenatal doctor will recommend you supplement right from the start. They will put you a prescribed folic acid pills to you. The other thing is we worry about mercury contamination because most of us as adults don't worry too much about mercury poisoning anymore. I mean, even if we eat certain things that may have trace amounts, because most of us won't consume enough to be harmful. But with the developing embryo or fetus, it doesn't take that much. So mothers need to be careful, expectant mothers, not to consume mercury-laden fish. The best rule of thumb to use is little fish good, big fish bad. If it's a big fish like a tuna, for instance, or a shark, you don't want to be eating that. Big fish live long lives and have a chance to absorb a lot of mercury during their lifespan. Small fish that live shorter lives generally are much safer. So, things like what comes in a can? Sardines, things like sardines. You don't have to really worry about. They're small, short lifespan fish. They will not have soaked up a lot of mercury. Anyways, so little fish good, big fish bad. Maternal obesity can be a problem. So I just mentioned being malnourished. Obviously, the opposite is true as well. Too much weight can be a problem. A maternal age, we worry somewhat about those 35 and older. They're at greater risk of some kind of problems with the offspring. It doesn't mean they can't have a healthy pregnancy, of course, but just a greater risk. Risk starts going up for particularly for chromosome and genetic abnormalities. Okay, emotional states, feeling long periods of stress, I should say. It can be very dangerous. With long periods of stress, the cortisol hormone gets released into the mother's system. It does cross the placental barrier. The baby experiences the stress hormones. If the mother produces a lot of these and is under stress, constantly day after day, this can cause this long-term exposure can cause problems to the developing fetus. Things like depression, fear, and anxiety can also be problematic. I'm not going to worry about the paternal factors. You can read about those. A little chart in your book. So you can see just once again they have the different periods. You have the top here, and you can see the embryonic period goes from 2 to 8 weeks. It's got that yellow bar at the top, and you can see those bars below are colored red and blue. Red are the greater sensitivity periods. So you can see that most of them are certainly falling in the embryonic period. So I said that is the risky period. You can see all those red bars falling in that 2 to 8 week period. There's a few of them that go beyond 8 weeks, but mostly they have blue bars past the 8 week period, which are less sensitive. Where the developing organism is less sensitive to terotrogens. It doesn't mean there can't be significant problems, but the sensitivity is reduced. So we know that most problems do occur in the embryonic period. Okay. Now, prenatal care. I'm going to just talk about one slide here. I'm going to skip this first one. And I wanted to mention centering pregnancy. This is a kind of a newer type program that for many people in the U.S. is started to replace traditional prenatal care. It's a kind of a group session. The woman and her partner will come in, and they will have 10 to 12 people member groups of pregnant mothers with their partners, and they will have as it says here, they will be led by a physician or a certified nurse midwife, leading this group experience. So these sessions are much longer than a typical prenatal care visit. A typical visit would be about 15 minutes with your doctor. These sessions tend to last about an hour and a half, and they often will have like weekly or every 2 week sessions. So it's a lot more time spent learning about your pregnancy, and it is cost effective because you have 10 to 12 women at once being learning about their pregnancies with being led only by one physician or a nurse midwife. It is very cost effective. It's much cheaper than typical prenatal care, and it is becoming more and more popular. One of the or some of the benefits are listed at the bottom here: reduced preterm births, fewer low birth weight babies, fewer babies ending up in the NICU unit, um, the intensive care unit. And another one you could add to that list is higher breastfeeding rates. Sorry, I'm not talking correctly right now. Breastfeeding rates. Okay. Yeah, and they find higher. So it's been very beneficial, this new kind of group experience for prenatal care. Okay, and our final main topic is birth, and we will start with the birth process and the 3 stages of the birth process. During the first stage, um, uterine contractions are 15 to 20 minutes apart, so they're sporadic. They last up to 1 minute in length. This is the longest stage. It can last 6 to 12 hours for a first pregnancy and a first birth. It tends to be less time for later births. So this is kind of the build up to the delivery. The second stage begins. Actually, before I go there, in the first stage will end once the cervix dilates to an opening of about 4 inches or 10 centimeters. This is what the contractions are doing. They're dilating and opening up the cervix. Once again, when it reaches about 4 inches or 10 centimeters, then it means the woman's ready to deliver. So the second stage begins when the baby's head starts to move through the cervix. So we see crowning take place. The top of the head can be seen. And this second stage is the delivery stage. It takes 45 minutes to an hour on average. Contractions during this stage come almost every minute. They last for about a minute each. So the contractions are coming, fast and furious. The woman is urged to push during the contractions, and the stage ends when the baby emerges from the mother's body. The third stage is the afterbirth stage. It typically only lasts about 5 minutes. The placental, the umbilical cord, and other membranes are detached and expelled. Typically, most mothers find this afterbirth fairly pain-free, although I've heard from some that it can still be painful, but probably not like the second stage when the baby was coming out. Okay, going on here. Most of our births in the United States take place in hospitals. You can see the overwhelming percent there, 98.5%. We are a medical society. We believe in medical treatments. Out of the 1.5% that take place outside of hospitals, 63% of those 1.5% are home deliveries, 31% in birthing centers. The birthing centers that they have now are pretty fantastic. I mean, it's very homey, and it feels more like you're in a hotel room or something, a nice hotel room rather than in a hospital. They can be very pleasant places. Midwives are at 8% of hospital births. This is much lower than in many other countries. So once again, we are a medical society. So we like hospitals, we like doctors delivering our babies. But 8%, I mean, it has actually gone up from the past. So a midwife will actually deliver the baby. So they have that medical training to assist in the delivery. A doula, on the other hand, is a person that provides physical, emotional support to the mother before, during, and after the childbirth, but they do not actually deliver the baby. So, in the doula would spend more time than the midwife does with the mother. They are a real emotional support, spending a lot of time with the mother throughout the pregnancy and throughout the birth. Okay. Methods of childbirth. Obviously, because we are a medical society and we have doctors delivering our babies in hospitals, many of us also choose to use medication. An analgesia is a pain relief drug, whereas an anesthesia will block sensation, or in some cases you could use it to even block consciousness. Typically, though, it's used to block sensation in the lower part of the body, where the mother won't even feel that part of the body anymore. So once again, analgesia, pain relief, anesthesia blocks sensation. Oxytocin is something that the doctors could use to stimulate contractions in the mother if the contractions are not progressing the way they should be, or if they have not started and then the baby needs to come out, they could use this to start contractions. Natural childbirth. This reduces the mother pain by decreasing her fear through education about childbirth. The idea is if you know about what to expect, you will be less fearful of it. Relaxation techniques are taught for during delivery. One type of natural childbirth is specifically called prepared childbirth. It's using the Lamaze method. And this teaches you a breathing technique that helps with pain relief. Okay. Going on here. With a natural childbirth, in case I didn't make it clear, there are no drugs given during the birth process. So it is meant to be drug-free and natural. And I wanted also to point out that the Lamaze method, the prepared childbirth Lamaze method, has become more popular in recent years in the U.S., even though, once again, we are more of I keep saying that we're a medical society, we like our drugs in our hospitals. I mean, there is, more of a movement towards this, the using breathing methods and the Lamaze method to help control pain rather than drugs. There's a number of studies that have been conducted that shows that infants born using, prepared or natural childbirth, there are advantages to it. If there are no, drugs in the mother's system, that the babies do come out more responsive and typically have higher APGAR scores. One other type of childbirth, of course, is cesarean delivery, which is surgically removing the baby through an abdominal incision. This would be done if the baby is in a breech position, meaning that it's coming out the wrong way. It's not coming out head first. The feet are presenting first. And if they can't get the baby turned around, they should not take the baby out that way. If there's fetal distress, so if the baby's in trouble, they may go quickly to a cesarean. Other reasons are maternal vaginal bleeding, or a natural birth has been hindered by an epidural. That can if an epidural is given late in the process in what was supposed to be a natural childbirth, it will often kind of slow down or hinder the natural contractions, and the cervix may stop opening, and they have to go to cesarean then. Anyways, there's been a lot of debate about cesareans. The World Health Organization states that a country's rate should be 10% of births or less done by cesarean. In 2015, the U.S. rate was 32%. So about a third of all births were by cesarean delivery. So we are way higher than what the World Health Organization recommends for a country. Once again, this goes back to the point I keep making. We are a medical society. We have the cesarean delivery down pat. Hospitals like to use it because it's a well-known procedure. It actually presents them with less risks and less chances of lawsuits if anything goes wrong. I mean, they know how to do cesareans, so let's just say that. And if they think that there's any chance of natural or prepared childbirth is going wrong, they kind of want to quickly go to cesarean in many hospitals, just to reduce the chance of a problem with the baby and a possible lawsuit. Okay, let me go on. One other birthing method or type of birth is some becoming somewhat more popular, although it's not allowed in every state, is a water birth. This is giving birth, in water while laying in water. It creates an environment similar to that of inside the amniotic sac. Remember, the baby, the fetus, I should say, has been floating around in amniotic fluid for months and months. It is what it's used to. It's comforting and warm and it helps to dilute noises. It's been said that the typical birth is very stressful to a fetus, going from a warm, dark, quiet environment to a noisy, bright, delivery room it's very stressful. So the water birth is meant to relieve the stress of the baby as it comes out into warm water, which would help dilute sounds and whatnot. And so it's a more gradual entry into our world. Okay, one more thing to cover is the assessing the newborn. We're going to look at the APGAR scale, and it assesses the newborns at both 1 and 5 minutes after birth. They like to do the 2 tests at 1 and 5 minutes because you want to see how the numbers change. What you hope, of course, is that the numbers improve, at the 5-minute mark compared to the 1-minute mark after birth. It's very typical that a baby won't score perfectly at the 1-minute mark, so you see if the numbers rise by 5 minutes, or if they're lowering, that would tell you that there's danger and that the baby's worsening. So you want the 2 measurements so you can do comparisons. The 5 things that get measured are listed here: the infant's heart rate, respiratory effort, which is their breathing, the muscle tone, are they moving their limbs and whatnot, body color, you want it pinkish rather than blue. Blue would tell you, of course, that it's lacking oxygen. Reflex irritability, is the baby responding to stimuli? This can be shown if the baby coughs, that's a reflex. If the baby cries out, that's a reflex. So is the baby responding to stimuli? That tells you that the nervous system's functioning. So anyways, if babies do end up with low APGAR scales, it has been associated with long-term educational support, ADHD, and developmental risks. And this is, once again, this is just like right after birth, these scores are being taken, and already it's an indicator that there could be long-term problems if the scores are low. This is the rubric that they use, or the chart that they use for the scoring system. So once again, you can see the 5 elements being tested on the left side, and then there are for each of the elements, the baby receives a 0, 1, or 2 score. So there's 5 characteristics between 0 and 2 points each. So a maximum score would be at 10 points. A minimum score would be 0, which would, I'm not being callous, that would basically mean the baby was born stillborn, or the baby was probably not alive if it had a 0 score. Okay, but so it's a score from 0 to 10 possible. If the baby scores 7 or higher, so between 7 and 10, it's considered in good condition. But once again, you don't need a perfect 10 score. Some of these things will be off particularly at the 1 minute mark. It may be a little blue. It may not be breathing quite regularly, at this point, or the heart rate might not be quite where you want it. So it's not uncommon that some of these are going to get less than 2 at the 1 minute mark. And once again, then you want to see the number improve at the 5 minute mark. So 7 to 10 is considered good condition. Between 4 and 6 means the baby needs some form of assistance. If the score is 3 or lower, it means the baby is in serious danger and needs medical attention. It is an emergency situation and the survival is in doubt for a score of 3 or less. Okay. There are two other scales, that also get used in different situations. I want you guys to read about these on your own. And I'm actually going to be stopping in 1 minute. Really quick, I'm just going to go ahead and show you what's left. I'm not covering this during this lecture. These are parts I want you to read on your own. Preterm and low birth weight infants. It's an important section to read and know. So there's a few slides on it. And then there's a last section on postpartum period. And make sure you read about that as well. Thank you very much, everyone. And I'll see you all next week. Remember, you have a test you can take any time from Thursday at noon until Sunday at noon. You have a paper due Saturday at noon. Have a great day, everyone.